Good evening. Ian Hart speaking on behalf of both co-presidents. It is my honor to welcome our guest, Dr. Jesse Ehrenfeld. I was joking with him earlier today that it's become a test of my friends if they are willing to come visit me in Rochester in January. He passed the test, so he is a true friend, and I am so happy that he's here to share time with us. So we've known each other for what we guess is about 20 years. So I've been privileged to watch his career blossom to where it is now. He told me not to bore you with all the details, so I'm going to give you the short and sweet version of Jesse's career. Jesse Ehrenfeld is currently a senior associate dean, a tenured professor of anesthesiology, and director of the Advancing a Healthier Wisconsin Endowment at the Medical College of Wisconsin. He is also professor of anesthesiology and health policy at Vanderbilt University. He was elected to the AMA Board of Trustees in 2014. Jesse is going to speak to us about his journey, about AMA's role, and about AI and digital health, and hopefully also give us some pearls of wisdom that we can take into our practice immediately. So it's not a tall order for such a giant man in the advocacy world. So thank you. Please welcome Dr. Jesse Ehrenfeld.
Very, very, very kind introduction. Thanks for having me. It is such a treat to be here. It's been about 10 years since I've been to Rochester, and I can't think of a better occasion to come and spend an evening with you. It's particularly fun to be here and actually see some people in an audience as opposed to just on the other side of a computer screen. So I know it's limited in terms of who's in the room, but thanks to everyone who's joining us online, and thank you to everyone who's here, the officers of the society, as well as the award recipients this evening. Congratulations to all of you. This is my background on the slide. Thank you, Dion, for not going through all of the details, but I've had an incredible journey thus far with still a little bit of runway ahead of me, and currently spend most of my time in Milwaukee, where I see patients a day a week, and then the rest of my time devoted to trying to improve the health of our communities, a shared mission, I think, with everybody in this room, particularly tonight. You know, when I think about the physician response to coronavirus, it's really remarkable to think back to what's happened, all that's changed over the last 2 years, despite widespread vaccine adoption, even for now as kids as young as 5. You know, we've got a new variant that is fueling pandemic surges around the country and continues to stoke fear and uncertainty for so many across the globe. COVID is one of the greatest public health threats that we have faced in generations, and its true impact on health, on the economy, and our way of life, we still don't know. What we do know, though, is that as physicians, we have to be credible sources of information about the virus, vaccine science. We have to continue to build confidence that vaccines are safe and effective, and that they are our best defense against all of the variants that are out there, and that vaccinations are the surest way to reduce the human toll and ultimately bring an end to the pandemic. One of the most concerning aspects of all of this has been the outrageous, and that's the right word, amount of misinformation and half-truths that have been promulgated by a lot of so-called experts. For physicians, those of us on the front lines, dedicated to saving our patients' lives, the torrent of misinformation has been disheartening and at times just downright devastating. I've got a pretty radical idea. When it comes to healthcare and medicine, I think that doctors should be the loudest voices in the room, not politicians, not TV hosts, not celebrities, not even Aaron Rodgers, not the people who peddle conspiracy theories. Our society has to put trust back in doctors to pull us out of the crisis ahead, instead of pundits, media personalities that we see on TV too often. Doesn't really seem like that radical of an idea. We've seen during the pandemic how much the public needs our guidance. More now than ever, they need our help to make sense of all of what's going on out there, to tell them what's safe to do and what's not. Unfortunately, we're at a place today where the public, many of our patients that we serve, are more likely to listen to an uninformed opinion on television or a fringe website than take the advice of their own physician. So as physicians, as leaders in medicine, we have to find a way to cut through the nonsense and take back America's ear. We need to make sure that we are the loudest voice in the room when it comes to healthcare policy, and to what's necessary and prudent to keep the public safe. I don't think it's that radical. I think it just makes good sense. And that's really what we're trying to achieve at the AMA. So what has the AMA response to COVID looked like? Since the beginning of the pandemic, our top priority has been to deliver the tools and support to America's physicians that they need to fight against COVID, to fight for the resources that healthcare workers need to take care of our patients. And we've responded in a bunch of important ways, providing trusted evidence-based resources, clear guidance to physicians on the front lines, all of which can be accessed for free on our website, helping physicians and practices recover from the disruption and the damage that the pandemic has caused, providing guidelines on how to safely reopen, and pushing at the highest levels of government to deliver the necessary equipment to keep our patients and ourselves safe, PPE, and reduce the obstacles to patient care. As I mentioned a minute ago, probably the most disturbing aspect has been the degree of misinformation, disinformation, and the politicization of the medical crisis. The rampant misinformation online, the politicization of health issues has eroded confidence from the public in science and has undermined trust in physicians and medical institutions. And these trends have existed for decades, but they've become particularly acute during this pandemic. And unfortunately, as the pandemic has unfolded, we've seen scientific advisors, sound medical advice, and even physicians demonized for political purposes. We're fighting a war on two fronts, caring for those who are ill during a raging pandemic, while at the same time battling a public relations battle that questions the legitimacy of our work and our motives. I mean, we were called out by leaders in government for having financial interests in hoping that people got sick. I mean, it was unbelievably difficult to hear that from our elected leaders. We've got real challenges. We have to base decisions on scientific evidence, data quality, and equity, and it's important that we make sure that our leaders are guided by those experts who actually understand the science. So where are we today? We've got new COVID infections at an all-time high, starting to see some relief in certain parts of the country, but not everywhere. Widespread breakthrough cases primarily in the unvaccinated who face a much higher risk of severe illness and adverse outcomes. Vaccines, boosters, and masks are the key to controlling the pandemic. And misinformation and outright falsehoods, unfortunately, continue to drive much of the opposition to vaccination. So to work to stop the virus, the AMA has joined 60 other leading healthcare organizations calling for mandatory vaccinations in healthcare workers. CMS has mandated this, subject of a bunch of lawsuits. It's held up thus far. Of course, we've got something like 450 million vaccines administered here in the US and something like 8 billion worldwide. And because of that, we know that these vaccines are safe. We know that they're highly effective at preventing severe illness and death, and we just have to get people vaccinated. So, what is our role in vaccine adoption? Our patients have to have confidence in us, in the vaccines. The good news is that there's good research that shows that trusted voices can demystify the process of where these vaccines came from, how they came so quickly, and that the best messengers are influencers from within their own communities, often one's personal physician. So we know that well-targeted public education efforts can increase the number of people who are willing to be vaccinated, and all of us play an important role in this regard. A strong recommendation from a healthcare professional is a factor in getting people vaccinated. I was telling some of the students at lunch today, obviously I do a lot of policy work. I'm on the AMA board, but every patient for the last year that I've taken care of and taken the operating room, I've asked them, are you vaccinated and is your family vaccinated? The answer has often been yes. Sometimes it's been no. but I've had patients change their mind. And that requires all of us to do our part. The AMA has been really pleased to partner with other leading organizations in corporations in a national ad council campaign designed to educate the American public, build confidence in these vaccines. We were a founding partner of the Ad Council's COVID-19 Vaccine Education Initiative and the It's Up to You campaign, really designed to appeal to people's desire to protect themselves and their loved ones from this deadly virus so we can get back to the moments that we all desperately miss. As we've been through this 2 years in, we've also been thinking about how do we prepare for the next pandemic. We've learned a lot about our health systems and gaps in our health systems and the public health systems. We know that we need to do things, put safeguards in place to prevent this from happening again. We need better coordination across federal and state government, better diagnostic testing infrastructure, a process to accelerate vaccine and therapeutic development. We need better state and federal stockpiles of supplies and PPE, and a much more comprehensive data collection strategy. We still do not know in America today how many healthcare workers are vaccinated. It's unbelievable to me that we just don't have that information. The pandemic response has also led to a paradigm shift in terms of how we use telehealth and other technologies. This is a trend that will continue to grow. The Mayo Clinic, I know, because you guys published it, had a 11,000% increase in virtual visits in the first few months of the pandemic. We know that people like these approaches and these technologies. The AMA has strongly supported a shift towards telemedicine. We have advocated that it is a lifeline for many of our patients, our practices, and physicians. However, one of the most significant barriers to its adoption has been restrictions on where patients can be located to receive services under Medicare rules. And so at our urging, CMS temporarily removed those restrictions, allowing Medicare patients to get telemedicine services at home, no matter where those homes happen to be. We're trying to get those changes to become permanent, working with Congress, HHS, and other policymakers to try to make it easier for physicians to provide remote care across the country. We've also got a lot of resources to try to help physicians implement telehealth, and if folks are interested in looking at where those are, I can point to them. Having mentioned telehealth, the impact of the pandemic, I thought I would shift gears to talk about how the AMA has been supporting physician use and adoption of health technologies. This is my son, Ethan, and he was born 10 weeks early. He weighed 2 pounds, 7 ounces. That picture on the left I took as he was being wheeled out of the operating room into the neonatal ICU. They stopped for 2 seconds. We got to look at him, picture, and off they went. I'm glad they didn't stop for longer. So 1,100 grams, 50 days in the neonatal ICU at Illinois Masonic in Chicago, where he required a variety of medical devices to keep him alive, technologies and innovations for which I am eternally grateful. Some technologies that are more than 100 years old, the warm air incubators developed in Paris in the 1880s. Other technologies much more recently brought into practice, pulse oximetry from the 70s, smart infusion pumps from the 2000s. You know, I love sharing pictures of my son, and I've got thousands of them. I won't. Could talk about them all day long. I like to show these photos of him in the ICU because it reminds me not just of the medical technologies that work, but also the dangers associated with those that failed. Some of you may be familiar with Joel Nobel and the ECRI Institute. Joel was a surgeon, he was an inventor, and he founded ECRI in the 1960s after a 4-year-old boy died in his arms when a defibrillator failed to work properly. He used that institute to focus his efforts on improving CPR technology, design, and deployment, and it really ushered in an era of comparative evaluation of medical device brands in the 70s, including some very famous work around deaths and injuries to neonates in incubators, where there was a consistent problem with thermostat failure, incubator overheating, infant hypothermia, and other malfunctions and design defects that led to fire and shock hazards. Now, fortunately, Ethan's incubator worked just fine. This is a picture I took of him Sunday morning just before I hopped in the car to drive up from Milwaukee. He didn't get electrocuted in his incubator. And it's because of standards, regulations that have transformed the medical device industry over the last 50 years. In some ways, Ethan's a modern medical miracle, right? In other ways, he's just benefited from the seamless integration of routinely available technologies. And much of that work has been at the centerpiece of standards to protect patients like my son Ethan, from harm when they're vulnerable. So as I share this, I think about the development and implementation of new technologies, particularly those that are AI enabled, where it can be much more difficult to understand when something is working as expected or it's not. The tragic losses of 2 Boeing 737 MAX airliners provide us with some insight, lessons on how AI systems should and should not be implemented in medicine. Automated systems designed to improve safety can actually cause harm and danger when they malfunction. And the effects of an AI system are determined by the implementation, not by the intent of the person who designed the system. So the 737 MAX had something called MCAS, the Maneuvering Characteristics Automation System. And this is what we think caused both of those crashes. It's a safety system designed to mitigate a known risk with the 737 MAX redesign. So I'll get technical here for a second. So modern high efficiency turbofan engines, much larger in diameter than those that were used in the 60s when the planes were originally designed. So if you mount them in the original configuration, it risks dragging them on the ground. So to deal with this, the 737 MAX redesign made these newer, larger engines fit by putting them further forward and higher on the wing. Unfortunately, that new engine position can cause the nose of the plane to pitch up during some maneuvers. And if you pitch an airplane's nose up, it's dangerous because it increases the angle of attack. And if that angle is too steep, the plane stalls and falls out of the sky. So to mitigate the propensity for dangerous stalls, what the 737 MAX did is it had this AI-enabled safety system, MCAS, to monitor that angle of attack sensor. When it detects a high angle of attack, it forces the nose of the plane down, reducing it. However, if there's a sensor malfunction, then MCAS forces the nose of the plane down into the ground. And that appears to be what happened with those 2 absolutely devastating crashes. So how does that relate to medicine? Well, when AI systems are added to medical workflows, devices, or software, the people in those workflows have to be made aware that the AI exists. We have to get training on how it's expected to function and what anticipated dysfunction might look like. People working with AI can only supervise and correct it if you know that it's there, the outputs it's producing, and sadly, the flight crews of those 2 lost planes were not aware of the existence of the new AI systems on their aircraft. It was not in the operations manual. There was no specific training provided to those crews. We simply cannot repeat the same mistake in healthcare. So AI is everywhere. I don't think anyone would argue that we're not in an AI era. These tools track our data, the music we listen to, give us recommendations for things I might like to hear on the road on the way home. Target, Walmart, Amazon, my grocery store, they all know what I shop for. They give me suggestions on things to buy, recipes to try. We expect AI to make our lives better based on what we're doing, to make our lives more efficient. But when it comes to healthcare, we're often not as comfortable taking recommendations from something that we can't see or speak to or know how it was validated. At the same time, there's this deluge of data hitting us every day that we have to sift through. So I propose that we have to embrace this concept of augmenting our intelligence to help us as clinicians, not to replace cognition, but to boost it. AI systems have tremendous strengths in processing, NLP, and machine learning, eliminating bias, and of course, they have an absolutely endless capacity for work. They never take a day off. Humans, however, we excel through our cognitive processes in different areas: common sense, moral dilemmas, having compassion, having imagination, abstracting. We know, however, that these things together can be more powerful than any alone. This is a study that I love. It's a little dated, but it compared a really great, the best at the time, 2015 symptom checker, automated, to physicians. And the computer symptom checker was right about 20% of the time. The average physician was right about 2/3 of the time. The magic is when you bring them together. Here, suddenly you can boost the accuracy of diagnosis up to 93%. I have been on the AMA board the last 7 years and have done a lot of work trying to understand and think about these systems and how they can be improved. Some of that, for me, was informed by work I did overseas. So I spent 10 years in the Navy as a reservist. This is a picture I took in sunny Kandahar, Afghanistan, where I was staffing a combat trauma hospital in the southern half of the country, and found myself really surprised when I'm in the trauma bay, patients brought to me, and nobody can tell me if the patient had CPR or not. And in this setting, that's really important because we're resource limited. And if you have had CPR, unlikely to survive, we make a different triage decision. But that information, which is not subtle, if you're pumping on somebody's chest, nobody could tell me. And you ask yourself, why is that? When you're in combat, it's dark, there are multiple casualties, it's loud, there's a helicopter, it's really easy for information to get lost. So some of the direct work I've been involved in trying to bring forward is around how do we use AI tools and systems to automatically detect systems in real time. And this is a simulation activity. These are two of my colleagues demonstrating that, when you do routine interventions on the back of an ambulance, and we partnered with the paramedics and fire department in Nashville at Vanderbilt to do this work. If you put sensors and accelerometer on the wrist of somebody who's doing a medical intervention and mount a video camera in the back of a rig, then you can actually infer what they're doing based on data streams in real time that you can then do a lot of things with. You can provide that information upstream to receiving facilities. You can use it to generate a care record. You can use it for real-time clinical decision support when you don't have to wait for somebody to document. And I'll tell you, nobody's documenting anything on a helicopter. So this is some of the work that I've been personally involved in the AI space. Now, the AMA has a 21-member board of trustees. This is the last board photo that we have because after this COVID arrived and we haven't been together. By the way, I do think I have the best sock choice. So this was taken the year that I was chair, hence I got to sit in the middle. Very diverse group representing all specialties, geographies, and I have been on the board since 2014 and served as chair in 2019, 2020. The AMA's broad work across healthcare is really focused in 3 core areas: removing the obstacles that interfere with our ability to care for patients, leading the charge to confront public health crises, and trying to drive the future of medicine, and understanding how we can support the use and implementation of technology. AI tools underpins a lot of this work. So, okay, you have a new technology, a new device, a new innovation. You can be a physician innovator, you can be a startup, you can be a medical device company. What do you want to do with your technology? Well, you want to get it into the marketplace. And you can have the best new widget in the world, but no one's going to buy it if there's no way for that to get paid for and reimbursed. And how do we get things paid for in our country? Well, it's mostly driven by third-party payers and things like coverage related to CPT codes. So, CPT is something that the AMA created and is the language of medicine. And frankly, we think the code to the future. It's how we assign every task, every service, everything that we do, a framework for terminology for reporting services and diagnosis. Understanding how CPT needs to evolve to support new technologies has been a key priority for the AMA. It is an evidence-based, constantly updated open process. People often think of CPT as a black box. I get a code update, it's there, where'd it come from? It's not. This is a little diagram that kind of shows how things evolve. It is an open process and it's market driven. It includes representatives from obviously the physician community, but also payers, industry, other professionals. And as CPT has evolved, the AMA has recognized that we need to rethink digital medicine, particularly around coding, coverage, and payment. So to that end, we recognize that we need to bring folks together. We've convened something called the Digital Medicine Payment Advisory Group to understand how do we create codes for remote monitoring and for internet consultations, and how do we get broader coverage for those services. And this is all obviously related to our advocacy work with CMS. I will share with you that we announced last week, so I wouldn't be surprised if none of you were aware of this, a new program for CPT developers. This facilitates access to AMA's expertise, our content, our resources, so that at the really crucial stage of development and innovation, people can actually start to think about how these things get coded. So we're providing royalty-free access to CPT for developers to test things during the product development stage, access to the AMA intelligence platform, and different ways that developers can engage with us. And we're really excited about this new program that was just announced last week. The AMA has also done a lot of work to think about how can we take the Silicon Valley venture-backed approach, how can we support innovation and make sure that physicians have a seat at the table in the design and development stages of new technology, not after the fact as a focus group because you have to tell the FDA that you have one. And so to do this, in 2017, we founded a company in Silicon Valley called Health 2047. I sat on its board for a few years. Health 2047 is not a startup. It's an innovation company owned by the AMA to birth startups. And it brings together corporate partners, innovators, AMA members from across medicine to identify critical needs, develop solutions with the goal of spinning those off into companies. And they've already spun out a bunch of companies, and there's work in the chronic disease management space. There is a lot of work around trying to support private practices, a lot of work trying to engage underserved communities in clinical research using platform approaches. And it's a very exciting tool as we think about ways that the AMA can support innovation across medicine in new ways that we haven't typically done historically. We also have something called the Physician Innovation Network. This is a free platform available to anybody, and it connects the world of medicine with technology solution drivers. It's got something like 15,000 users on it, 30 organizational collaborators. This is free, it's online. Students, residents, physicians, innovators, everybody can get on there to hopefully help us get better technologies brought to the marketplaces. Now, of course, no organization can take on these challenges alone. The AMA can't. That's why we're collaborating with a lot of the top stakeholders in medicine and technology, academia, on trying to bring forward broad solutions that will improve our clinical environments and, most importantly, improve our patients' outcomes. I thought I would turn next to some research that the AMA has done, trying to understanding what are the motivators for physicians to adopt new technologies and what are the barriers and requirements to adoption of these tools. I'll kind of cover what we've learned and how these things have shifted over time. We've done this serially using nationally representative samples. So I'll show you data from 2016 and 2019 to track trends, and we'll be fielding a new survey in 2022 to see how things have shifted. I will give the small caveat that, of course, the 2019 data is all pre-pandemic, so take this with a grain of salt. In 2016, we started this work, we've repeated it, and the goals were really to understand changes in overall interest in these tools, familiarity with a group of 7 kinds of tools that we think kind of capture what's happening in the development place. And then for each tool, we kind of looked at what are the motivators for folks to actually bring these things into their practice. There has been a small but significant increase in the advantage that physicians feel these solutions bring to their ability to care for patients. The use of digital health tools overall has risen significantly. Telehealth has seen the greatest growth, and I'm sure that during COVID, this has gone up even more. The average number of digital tools people are using has increased. And what's interesting is that older physicians Those who are less enthusiastic about technology, and they're not exactly the same, but there's a lot of overlap, are starting to catch up in their use of these tools. Use by solo practice physicians has also gone up. They had been lagging behind other physicians in 2016, but they're now closer to the average. And while all digital tools have gone up, remote care tools have seen the biggest moves forward and also the highest likelihood of adoption within the next 3 years. When asked about these digital tools, remote ones are the ones that there's the most enthusiastic support for gaining traction. And multi-specialty groups currently the heaviest users of these kinds of technologies. Now, improved efficiency and increasing safety are the top motivators for physicians to adopt these tools. And there's been a significant shift in the importance of remote care in terms of people thinking, what is it going to take for these things to come into adoption? Two elements that are attracting physicians to these tools have shifted. Allows me to provide care remotely and helps reduce stress and burnout, now are into the quadrant of drivers, which is kind of interesting. Requirements for adopting these tools have not really changed significantly. Integrating with the EHR and being as good as traditional care, two key requirements that have not changed. The importance of these tools being covered by standard malpractice insurance has significantly increased as a requirement, and demonstrating that their safety, that there's efficacy in peer-reviewed publications has also gone up in importance. The degree of responsibility that physicians have a desire to adopt these things really hasn't changed, but the current and planned use of these tools did go up in 2019. Again, I expect that this would look markedly different and will look markedly different in 2022 when we do our post-COVID survey. What about emerging technologies? Awareness of augmented intelligence technologies is very, very high, even though adoption, those small bars, remain in the single digits for almost all of these tools. And in spite of that, the intention to adopt these tools within the next 3 years is very, very high, even though current use is low. So that tells me that there is tremendous enthusiasm, even though these tools in many places don't exist in the wild. Physicians most interested in seeing these technologies help them serve chronic care patients. And so the summary of these changes from 2016 to 2019 is here. More physicians using these tools seeing an advantage, adoption going across all physician types, remote monitoring and telehealth tools being the most increased, and a lot of awareness of emerging technologies like AI. I've talked a lot about these tools, what's in the future ahead. I thought I would take a step back and kind of ask the question, what creates health? And we know that access to quality healthcare is an aspect of healthy living, but a lot of others in the world, including the AMA, have recognized, and it's widely described, that there are social determinants that often drive health and well-being, much more so than access to care. Socioeconomic status, education, mobility, housing, employment, transportation, environmental quality, and of course, genetic factors do play a role as well. There is growing awareness around the country that we have to consider these social determinants when we're thinking about how do we improve health outcomes on a broad scale to bring about greater health equity across the system. So the question is, how should these factors influence our work in digital health technology, medical devices? And I would argue that they absolutely have to. And so I thought I would give you an example of why it's important for us to keep a health equity lens in mind when we think about digital technology. Cochlear implants are incredible. They bypass defective hair cells in the ear, take sound out from the environment, acoustic sound, transform it into electrical energy. You then stimulate the nerve. In somebody who is severely to profoundly or completely deaf, after implantation can have normal levels of hearing. These are phenomenal. If you are ever needing a pick-me-up late at night, go to Google, YouTube, one of these videos where they turn a device on for a child for the first time, and it will bring you to tears. These are implanted by otolaryngologists. As an anesthesiologist, I've participated in dozens of these procedures. But I will tell you, when you implant the internal device, that stays sewn in under the skin, it requires an external portion as well. Some of you may have seen patients with these. That piece is kind of like a hearing aid. But just because we've implanted this FDA-approved device surgically, doesn't mean that a child or an individual will wear the external part. And in one study, half of the participants with one of these devices didn't wear their external piece full time, meaning that half of the time their device was non-functional. It's not going to work if you don't wear the external piece. Why might that be? We know that food insecurity, housing instability correlate with poor medication adherence, and it's not hard to imagine why poverty, a lack of education, or stigma might make one patient less likely to be able to wear their device or buy the batteries that you need to have in the thing, which are, of course, are not covered by Medicaid or insurance. So as we think about the development of new technologies, new devices, I would argue that we have to consider everything we do from a health equity lens to ensure that our work is mindful of the barriers to health that were on the previous slide. Now, it's also clear to me, perhaps more now than ever, that during the pandemic, healthcare has been disrupted. Tremendous growth in retail and direct-to-consumer markets, increase in physicians going to work in new models of care, increasing patient use of these models. Millions of Americans have lost employer-sponsored health coverage during COVID, which makes a $40 doctor visit, at Walmart look pretty appealing to a lot of folks in America. Patients and physicians want virtual care to continue. 68% of physicians indicate that they're motivated to increase their telehealth practice. 75% think that it allows them to provide good, high-quality care. And J.D. Power, often in car ads on TV, they do a patient satisfaction practice score, and their score for telehealth was 860 out of 1,000, the highest that they have ever recorded across all of healthcare, insurance, and financial services. Pretty remarkable. Record digital health investment in 2020, 2021, something like 20 billion globally, all of which is powering tremendous advances in medical device digital technologies. We're also seeing new care delivery models already at work. There are tech-enabled healthcare services that provide healthcare through technology aimed at employers, pharmaceutical companies, payers, consumers. There are pure play healthcare services, companies that offer healthcare in person, leveraging technology for practice management, record keeping, billing, scheduling, all while at the same time, traditional healthcare systems, hospitals are being threatened by business models that have declining margins or negative margins, often upended by the pandemic, loss of patient volumes, incredibly sensitive to third-party market forces like third-party payer negotiations or a payer market shift. We're also facing a national healthcare crisis, and it's actually not even a national crisis, it's a global crisis. Our healthcare system simply can't meet the demand placed on us. That was prior to COVID. We've seen all across the globe, including in the US, that we've got a very tenuously balanced system when you think about how patients access services that's come crashing down. At the hospital where I work, we can do 4 surgeries a day that require an ICU bed. We used to do 20. We are telling patients with cancer that they can't have their surgery. It's devastating. Demand has far outstripped supply in lots of ways, supply chain, technology, human capital, and we are having these unprecedented challenges across the globe. Specialty shortages, people living longer, relative birth rates. There are demographic trends that are driving some of this, but we've also got physician burnout, people reducing their practices, being overwhelmed with data, and a technology design emphasis that often doesn't bring in what physicians really need at the forefront that are driving a lot of the challenges around the demand side of the equation. Furthermore, while every other industry in the country has had a progressive rise in productivity over the last several decades, this is Department of Labor data, I think it's cut off at the bottom there. Actually, in healthcare, it's gone the other way. We've had a downward trend, and there should be technology solutions that can help us with this. We need to make sure that as we bring technology solutions in the digital space into our practice, that they're real solutions and not just adding complexity. And you think about, the challenges for folks to use these technologies, particularly patients, and they are extraordinary. Technologies need to reduce the burden, simplify care, and a lot of technological advances today have actually done the opposite. They've increased complexity. Just look at polypharmacy, the rapid proliferation of digital solutions, the explosion of digital health apps, and there are some real challenges ahead. There are ways that we can work together to make these technologies an asset, not a burden, by promoting innovation that tackles the problems that we know are actually important, bringing physician perspectives to the forefront, the front end on the technology development cycle, not the back end, to ultimately allow us to do what we do best, which is to turn our attentions to our patients and not clicking buttons. I often get asked, can AI systems be deployed at scale to solve some of these challenges? And I'll wrap up by, giving you some vision for what I think the answer is, which is yes. If you read, any medical journals, go to panels, you'll hear how, AI systems can outperform physicians. I showed you that slide earlier. Yet too few of these systems have been deployed at scale. Talked about a lot, but fewer are actually out there streamlining, providing actionable information to us when we need it at the bedside. You've all seen this Gartner hype curve. It describes the visibility of new technology over time. We are clearly somewhere near that peak of inflated expectations. It's going to be a long, sad dive into that trough of disillusionments. Eventually, we will get out there to that plateau of productivity. The AMA has been thinking, how do we get there faster so that we don't live through an AI winter where there's frustration and all goes away? We've got to identify standards. We need to figure out what the role for real world evidence is and bring these things forward. We need to figure out how to address privacy considerations, make sure that we're not introducing bias, all while having a clear line of sight on the financial impact of these systems with an equity lens. And those are some of the urgent sort of priority areas that we've been thinking a lot about. We need to focus not just on the technology, but how the technology comes together with us as a human. And I love this quote from Abraham Verghese, who wrote Cutting for Stone out of Stanford. The way here is not to think technology versus human, but to ask how they come together where the sum can be greater than the parts for an equitable, inclusive, human and humane care in the practice of medicine. Because of that, the AMA has elected to use the term augmented intelligence. I've used it tonight as opposed to artificial, because we think that the idea here is not to replace us, the human cognition, but to augment it. And that's why we really think that this is the right term for us to be considering. If you're interested in learning more about AMA's perspectives, policy, or advocacy, these are 3 of the reports. There's several others out there that are available online for free that look at issues around payment regulation, how we think about a framework for implementation in healthcare, as well as issues related to incorporation in medical education, professional development, and credentialing systems. So I've gone through some of the deep data around physician perspectives on these technologies. The fundamental question, though, is what do physicians need to know to adopt these technologies? And how can the AMA support physicians and physician practices? We know that physicians need assurance that these technologies are safe, that they're efficacious, that there is coverage and payment available, that liabilities have been addressed, issues have been addressed, and that these innovations actually work in my practice with my patients, integrate into the workflow in the electronic health records. And for AI systems, I expect that there will be applications that will fundamentally transform how we practice. And physicians, our healthcare team colleagues, patients, we all need clear pathways to think about how do we navigate these transformations. And there are real challenges as we think about some of the ethical implications that need to be also contemplated with new technologies. It didn't take a global pandemic for the work of the AMA to resonate with physicians, students, residents. I'll close by saying that we just cannot change the system without the support of all of our members and the healthcare community. And that includes our state and county partners all across the country. 2021 marked 10 years of steady AMA growth among dues-paying members. Remarkable feat during a time of declining membership across all industries. And AMA membership has grown by more than 1/3 since 2011. And the dues-paying membership increase in 2020 was the greatest year-over-year jump that we've had in 70 years. This notable feat is because of a focused strategy to build our reputation, but also to create multiple physician points of engagement across our newly developed channels. I think this is a marker of our success, but also validation that we're on the right target as we think about what are the tools that we need, what is the work that we do day in and day out, even in a pandemic, to improve the clinical environment, our education systems, improve patient outcomes, and build sustainable systems. So physicians continue to place their trust in the AMA. They do that with their membership. They see us as a powerful ally, and I hope you all do too. My last slide took in the operating room. I counted, this was a neurosurgical procedure. I was doing spine surgery. There were 53 parameters that I was monitoring as the anesthesiologist, including 7 continuous waveforms. There's also EHR data, lab data, reminders to do things like redose the antibiotics that are all coming at me. You can't even see the patient, they're hidden away. Tucked away in the far back is Marshall. Marshall is our neuromonitoring tech, a technology that's been around since the 80s to monitor somatosensory evoked potentials. Gives you real-time feedback on the integrity of the spinal cord. Really important for the neurosurgeons to have those signals, see what those responses are so that they can tell if the sensory pathways are intact. Today, it requires a dedicated person to look at those streams of data in addition to all the things that I am doing. It's hard for me to imagine a future where AI approaches and tools don't help us do this work better. I don't know exactly what that looks like. I know that there are things that I miss. I know that there's subtle changes that a machine could pick up more quickly than I could, things that could help me be a better clinician. And I very much look forward to the day that we have technologies that allow us to do that in an evidence-based, validated, transparent way so that we know what's going on and can step in if there's a problem. And thank you all for having me. It's been such a treat to visit with you all, and I hope maybe someday I'll get to see some of you or host some of you in Milwaukee.